David.
Hi, everyone, and thanks, Amy. My name is David Grambowski, and I'm the professor here in the Department of Health Systems and Population Health, and also the director of our UW Center for Health Innovation and Policy Science, otherwise known as CHIPS. I want to welcome you to our seminar today. CHIPS is a relatively new center, and we tend to do health policy research related to healthcare systems, social determinants of health, and also state health policy. And with regard to that, when we think about how social determinants of health affect population health, housing is clearly at the top of the list in terms of a key driver of individual and population health, and also health disparities or inequities in health within population. And within CHIPS, Amy Hagopian and Jessica Jones-Smith have been spearheading a work group on housing and health. And an outgrowth of that has been a seminar series in this winter and spring quarter. And I'd like to now pass the baton to Amy Hagopian, who will introduce our speakers and the topic for today. Amy, take it away.
Thank you so much, Dave, and thank you to the Center for its support for this seminar series. One of the purposes of this series is to feature some of the many UW faculty who are active in the space of supporting people who are trying to survive while homeless in Seattle. And we have two great speakers for you on that theme today. So why this particular topic on harm reduction? We have a recent graduate in our School of Public Health, Rachel Scott, who just published her thesis on homeless mortality in King County, which she conducted in collaboration with the medical examiner's office, showing that about a third of the deaths among homeless folks in King County over the last decade were attributed to the harms of drug or alcohol, but these substances are implicated in other deaths too. I want to acknowledge, before I turn it over to the speakers, that one dominant narrative in our liberal city, which attributes homelessness to personal failings and poor choices, and says harm reduction simply enables more use and leads to chronic homelessness. And since that's what you're reading in the Seattle Times and on Como TV, we won't be giving that viewpoint more airtime here, but just to acknowledge it exists. I'm also teaching a class on homelessness this quarter, and hi to all my students who might be here, where we are debating the circular nature of homelessness and self-medication through drugs and alcohol for coping with the pain of living homeless. Seattle City Council did pass an ordinance in 2016 calling for the establishment of a safe injection site and funded it in 2019, but the mayor's office has never followed through on that. To acknowledge upstream drivers of drug use in our community, I just want to note, it's not our topic for today, but did people notice the news this week that the former president of Honduras was just arrested for overseeing a US-backed narco state, which smuggled 1 million pounds of cocaine into the United States since 2004. And I know our focus is on the individuals who took up some of the drugs that get smuggled into our country, but let's just notice that. So today we have two faculty with long-time commitments in the space of helping people with this problem. Both will talk about the goals of their work, which may not be to make everyone get sober. So to acknowledge that as well. Another thing to say is there are opportunities for you to get involved, including by attending the Transforming Our Communities conference in mid-June and doing student projects. So our first speaker today will be Dr. Caleb Bantagreen, whose main area of research is substance use disorders involving opioids and stimulants and interventions to support recovery and reduce substance-related harms. He's particularly interested in developing interventions that are accessible to all people, including those who are most marginalized, such as unhoused or in the criminal legal system. He provides technical assistance and evaluation services. You can check out the stopoverdose.org website and learnabouttreatment.org, where he consults. He earned his PhD in health services right here at UW and also holds UW graduate degrees in public health and social work. He got his BA in biology at Santa Cruz. He works as principal research scientist in the UW Addictions, Drug and Alcohol Institute. And our next speaker will be Seema Cliff-Assefi, who will introduce the concept of harm reduction at multiple levels: policy, community, and individual. She teaches practitioners about harm reduction through her position as an associate professor and co-director of the UW's Harm Reduction Research and Treatment Center at Harborview Medical Center. Her research lies at the intersection of substance use, mental health, criminal justice, and housing policy. Since 2006, she's been a part of several collaborative academic community-based research partnerships evaluating the effects of individual and community level harm reduction programs and interventions designed for people with lived experience of homelessness and substance use problems. She earned her BS in psychology at UW, her MSW at UW, and her PhD at Victoria University in Wellington, New Zealand. So welcome to both of you. I understand Caleb will go first, Seema will go next, Caleb will return, and then you'll chat amongst each other. So thanks to both of you so much for joining us.
Great, happy to be here. Thank you very much for the invitation. I am going to do a little bit of setup and then hand it over to Seema, who will give some additional details and sort of, there are a lot of different definitions of harm reduction, so it's important to sort of understand the different viewpoints and give some examples of their really exciting work. I'll share a few examples of my team's exciting work, and then really happy to have conversations. So, and I'm going to start very macro at the federal level. There's actually been a lot going on in the last year using the words harm reduction. I'm still not sure exactly how it's going to become manifest. I will share, because I think it's relevant. In 2012, I actually worked at the Office of National Drug Control Policy as a science advisor. And while I was there, we actually had the National Harm Reduction Coalition policy people come into the drug czar's office. And I actually went as an official representative back then to go to the Harm Reduction Coalition's national meeting. And we did a lot of work on naloxone, which you hear a lot about now. But as an example, I think as the overdose reversal medication naloxone has taken a solid 15 years to come from a grassroots-led intervention, entirely like the pure epitome of harm reduction, to being talked about federally, to finally being funded. And so I think that cycle is actually really interesting. I'm just going to show a couple of quick things here on screen, I think just for context, and I'll put the links in the chat as well. So what I want to show is not all that jumbled mess, but is specifically the Health and Human Services overdose prevention strategy in particular has always talked about, primary prevention, secondary prevention, tertiary prevention with different language, but is now starting to use language around harm reduction explicitly. And they give a few kind of concrete examples that I think are interesting. And as part of the conversations federally, the Substance Abuse Mental Health Services Administration at HHS had a couple of day harm reduction meeting in December, a lot about sort of defining terms and so on. And there's a lot going on around federal grants. There are CDC grants, these SAMHSA grants, NIH grants around harm reduction. And what Seema is really going to point out, and what I've learned from Seema and their group, is that harm reduction isn't about supplies. It's not about equipment. It's about people and relationships and engagement. And so sort of the kind words of advice I gave at this national meeting was to remind the feds of that, because the easiest thing to fund is some stuff. Like, it's easy to buy things. It's much harder to actually support people with money. That means paying them to actually do the work. including people with lived experience who have or are currently using drugs, which are really important people to involve in as part of the work as well. I will mention just here that we did do some substantial work. Susan Kingston led this work across Washington State around a structural intervention, which was the distribution of over 50,000 naloxone kits. One of the things I'll point to here, though, I think is really important, and I apologize, it's a little small. One of the important findings was law enforcement resistance or ambivalence about their role in overdose response and in addressing opioid use in the community can soften with appropriate training, resources, and administrative and leadership support. The way we made that emblematic in our work was by taking these $5 million from the feds and pushing the vast majority of it to local harm reduction agencies, where they controlled the funding. They were literally the experts in their community, and law enforcement and other community partners had to go to them to get training and to get supplies. It's just a relatively simple way to kind of flip the script about how money is distributed and how power is distributed. Couple of other quick things for background. I do think it's very important. It has been quite a whirlwind last year. It's been quite a whirlwind the last 2 weeks. I don't know if people followed this or not. This federal agency, SAMHSA, put out $30 million grant proposal announcement a couple of months ago around harm reduction nationally to fund, I can't remember, several dozen programs across the state. That is a tiny, tiny, tiny percentage of 1% of that budget. And the same week that the grants were due, some politicians noticed that safer smoking equipment could be funded with that grant. And that was immediately withdrawn back by the federal administration, that those actually couldn't do what the grant said you could do. So even as we make a couple of steps forward, there's still a step back. So it's just, there's always that tension. Coming down a little bit closer into Washington State, we have engrossed Senate Bill 5476, which does a bunch of things. It was in response to a state Supreme Court decision that decriminalized drugs. It created a new penalty, a more minor penalty for drugs, and allowed diversion, really using what was called law enforcement assisted diversion or LEAD model, a harm reduction model of case management. So that's a way that harm reduction has actually been officially put into state legislation, and a substantial amount of funding around a Recovery Navigator program in Washington State, with $45 million to be spent over 2 years using the sort of LEAD harm reduction model. Within that law also are some things about changing some drug paraphernalia law that would be more inclusive and allow making sure we have equipment for folks beyond those who just inject drugs. So that's super important. And then as Amy said, really importantly, locally in Seattle and across the state, how are we going to respond to substance use among people who are unused and or using in public? The pendulum is going back and forth so quickly, it's hard to tell what's happening sometimes, but it is bouncing around a lot. What I am reminded in the midst of all these conversations, whether it's federal or local, and I'll share with this group, perhaps it's obvious, but it's a reminder to myself that when you're having personal, clinical, or policy conversations, it's always worth taking multiple approaches, multiple lenses. Some of us believe in evidence. Some of us don't. I think other important approaches to bring along with evidence base are things around values, ethics, anti-racism. Those are very important and intrinsic within harm reduction. And then don't forget, as part of that evidence-based, sometimes you want to lead with cost savings, and that's fine. We can lead with cost savings depending on our audience. So I'll stop there for a little bit. I just wanted to give that as some background around sort of the policy and practice context.
Thanks, Caleb. I'm going to go ahead and share my screen. Let's see, you're going to see my very messy desktop in just 1 minute here. And hopefully, can you all see that okay? Okay, so I did make some slides to sort of guide the conversation. I'm going to give you a little bit of an overview of what we do at the Harm Reduction Research and Treatment Center, or the HART Center, which is our acronym. And I will say that over the past 15 years, I have had the honor and privilege of working alongside individuals experiencing both homelessness and substance use problems. And so most of my work over this past same amount of time has really been informed by the communities that I'm working to serve. So yeah, we're going to talk to you a little bit about these harm reduction approaches, specifically for people experiencing homelessness. And before I start, I do want to acknowledge that I live and work on these unceded ancestral lands of the Duwamish people. These are Seattle's first people who persist to this day, honoring their heritage and bringing cultural and social services to the tribal community. And I stand in solidarity with the Indigenous people of this land and want to thank and recognize the ancestors, both past, present, and future. And I believe it's important to acknowledge our history and how it has brought us to the present, namely so that we can identify better ways to move forward and ultimately heal. And the effects of colonization have meant devastating impacts for our Native communities. So for example, according to our most recent point in time count, our Native relatives make up roughly 10% of the population of people experiencing homelessness here in King County, despite making up only 1% of the overall population. So we really need to identify ways to repair the harms of colonization. One very small way that I do this is by providing rent to the Duwamish tribe, and you can too here at Real Rent Duwamish, and you can just put that into your Google search and that will take you to their website. So at the Harm Reduction Research and Treatment Center, our vision is really to reduce substance-related harm. So that is our focal point, strengthen communities and improve lives. And we do this by working collaboratively with people who use substances, as well as, pardon me, community members and organizations who serve these individuals, to really co-develop, evaluate, and disseminate evidence-based interventions that help to reduce substance-related harm and improve quality of life for folks. And we recognize that we can't talk about substance use without talking about racialized drug policies. Amy was mentioning kind of these global geopolitical forces at play, and the harms that are caused specifically to people of color through the implementation of many of these policies. We also can't talk about substance use without acknowledging the wealth inequality and societal factors that contribute to the conditions that we're seeing today here in our fair city. And I would say what sets our work apart at the Heart Center from many others who are working in substance use areas is that we do not ask people to stop using substances in order to get the help that they need. And we certainly don't force people into treatment or force treatment upon people, because our work has found that when people have intrinsic motivation to change, they're actually much more likely to sustain that change. And the impacts of forced and mandated treatment can actually be iatrogenic, which means harmful for people as well. So as I mentioned, I've been working alongside people experiencing homelessness over the past 15 years. And as you all are certainly aware, I'm sure, we have seen the homeless community rapidly growing here in Seattle, or at least visible homelessness. And people experiencing homelessness are disproportionately affected by medical, psychiatric, and substance use disorders. And I think, Amy, you were referring to one of the graduate students, Rachel Scott, looking at the deaths and the medical examiners from the medical examiner's office. So you heard already that about a third of the deaths are related to substance use. And really, we saw about 138 primarily preventable deaths in the homeless community. Rachel probably has the more recent numbers in terms of average age of death for people experiencing homelessness. At last record, I show that roughly between 49 and 52 years is the average mortality rate. And when you think about the fact that we are one of the, or if not the wealthiest country in the world, this just is absolutely not acceptable, and we need to do better. So I guess asking ourselves, what does better look like? In the context of substance use, ideally it would mean that our treatment systems would engage and effectively treat people with substance use disorders. And so this is really what we've been working towards at the Heart Center. And we're really doing this. Our research paradigm has really allowed us to involve community voices and create interventions that are with, by, and for the community while still maintaining scientific rigor. In all of our studies, we work collectively with the community to find out what is of most importance to them, what they believe will work or not work, what is acceptable and feasible, and what they want to see happen for themselves and their communities. And then we work together to build and test those programs, services, and interventions with accountability to that community. And I don't have time to talk about all of our approaches that we've co-developed with the community, but I did want to share about an inaugural study here in the Emerald City that I'm sure many of you are familiar with, but that I had the opportunity to be a part of, which really has set the stage for everything that I've been working on at the Heart Center over these past decade and a half. But before I do that, I did promise that I would define harm reduction. So maybe we should start with some definitions. So harm reduction can really be described as a low threshold and user-driven set of both compassionate and pragmatic approaches that are really in service of reducing substance-related harm, but also improving quality of life for both individuals and the communities alike. The difference between harm reduction interventions and other interventions that are available for other people experiencing substance use disorders is that, as I said earlier, harm reduction interventions do not require that people become abstinent or even reduce their use in order to get the help that they need. And this is very different from our kind of models that we have in play. And there are two kind of defining components of harm reduction. So really the philosophy behind harm reduction is compassion. We acknowledge that people who use substances do so for a reason, and they may be getting something out of their substance use. So very kind of functional approach, which I think, Caleb, you're probably going to talk a little bit about in a bit. And the pros and cons are important to acknowledge so that we, as clinicians who work with people, as I'm a clinician who works with people experiencing substance use problems, so we can better understand the perspectives of our clients, not only to build rapport with them, but also to help them come up with a tailored, individualized plan to achieve the positive things they want to see from their substance use while minimizing the harms associated with their use. And I do want to be really clear here in saying that harm reduction does not negate the negative consequences of substance use. We just view substance use as more balanced with less of a value judgment. And we also acknowledge that substance use is here to stay. I mean, it's been around since the beginning of time. It's probably not the best use of our time as providers and clinicians and community members to focus on eradicating a basic human behavior that has been around for millennia. Instead, we're pragmatists, right? We want to work towards helping reduce substance-related harm now in our communities for the individual and for the larger community. And we acknowledge, again, pointing back to what Amy was talking about, we acknowledge substance use exists in a larger social context, pardon me. So what's defined as substance use and substance use disorders can change very dramatically from culture to culture across time. Often these are socially defined and socially constructed concepts. And that means that substance use is truly complex. It's not a true actual disorder that resides within an individual. Exactly like Amy was talking about with the geopolitical forces in play, substance use is a product of much larger familial, community-wide geopolitical forces that are sometimes not under our direct control. And I think it's very important as a harm reductionist to really look at these factors, because we often do end up putting the blame on the individual. Why did they fail treatment? What is it about this person that means that they're living on the streets homeless? And we're not looking at these larger factors that are really in play that are creating these conditions, like wealth inequality, for example. So finally, we want to acknowledge that substance use is not the client. Our clients and participants are valued community members, and are much more than just their substance use. It's important to view the person using substances or experiencing homelessness as a holistic human being. And the approach of harm reduction is also pragmatic. It's very client driven. It's helpful in engaging people who are not going to be engaged by traditional abstinence based methods. It's a non judgmental approach. So it's not placing these value judgments like I was talking about on substance use. It's not necessarily about use reduction per se, but the mitigation of harm is the end point. It's the end goal for this set of approaches. And that does not exclude abstinence. If that is what the person wants to work towards, as harm reductionists, we absolutely work with them to get there. But the goal is to reduce the harm that they're experiencing from the substance, and focus on their quality of life. So on the one hand, it's reducing harm. On the other hand, and an important corollary is improving quality of life. Also, harm reduction is open to the power of any positive change. Oftentimes, as clinicians, community members who are part of maybe the mainstream narrative, we see incremental changes as not enough. And with a harm reduction approach, we really acknowledge that what we may think looks like a small step might be actually a really huge leap for some of the people that we're working with. So we really want to reinforce even what might be viewed as a small incremental step towards positive behavior change, because we know intrinsic motivation is really a guide to healing. And harm reduction can be applied to various types of behaviors, risky health-related behaviors, for example. Obviously, in the context of the work that I do, substance use is at the focal point. So that is where I focus on harm reduction. Most people, when they hear harm reduction, they think about things like syringe exchanges, condom use. But I want to point out, like, things like seatbelts, helmets, all of those things can also be a form of harm reduction. And this collage here is kind of different kinds of applications of harm reduction. And as I said, I'm focusing mostly on harm reduction as applied to substance use. But I do want to note the following, because I think this is really important. While my work focuses on the intersection of homelessness and substance use, that does not mean that all people experiencing homelessness use substances. And in fact, this is a common misperception. And the reality is that while it is true that people experiencing homelessness tend to have higher prevalence rates of substance use problems than the general population, it is not true that everyone who is homeless uses or misuses substances. So I think that's a really important point to make, because I think the narrative that we're seeing right now, we're seeing visible homelessness and we're seeing visible substance use. And so when we're looking at like case studies, right, we might then make assumptions about the larger picture. But I think that is important to know. And then harm reduction may be applied on various levels. Caleb already alluded to this. We've got individual harm reduction, community-based, societal, and across various areas like prevention, treatment, policy, advocacy, and education. And between Caleb's work and our work at the Heart Center, I think we pretty well cover most of these various levels of harm reduction. Its broad scope sort of makes it this flexible and universally adaptable approach that has the potential to achieve high levels of effectiveness and reach. So just as like snippets of examples, like an example of policy-based harm reduction would be what Caleb was referring to earlier, drug decriminalization or legalization. So at the policy levels, these state bills that are coming out. Population-based might be something like a public service announcement. So those of you who may remember the friends don't let friends drink and drive. We're not saying don't drink. We are saying if you are going to drink, don't drive, because we know that that is drinking and driving lead to a lot of alcohol related death. Also, things like overdose awareness campaigns and a lot of the work that Caleb has done around Stop Overdose fall into that category. Community-based, whatever is working within the community. We have, for example, here in our community and now adopted into federal best practices is low barrier, non-abstinence based housing. So I guess that kind of falls on a community level and also on a policy level. And my work has primarily focused on the community-based and individually oriented harm reduction interventions, while occasionally intersecting with the policy sector. While Caleb's work has really spanned across all of these various levels. And just real quick to give you an overview, and then we'll go back to hearing more from Caleb. So we're talking about harm reduction approaches here in the Emerald City of Seattle, and meeting people where they are. And I just wanted to take you all back to the start of my trajectory working in this field, and detail one of the original and effective harm reduction approaches that has effectively addressed homelessness in Seattle for nearly 20 years. And that is 1811 Eastlake. 1811 Eastlake is owned and operated by the Downtown Emergency Service Center. They're the largest providers of housing and clinical services to people experiencing homelessness here in the Seattle area. And this particular house was and remains the first single site Housing First program in the country. So Housing First has often been dubbed as harm reduction housing. It's a low barrier, non-abstinence based approach that is predicated on the belief that housing is a human right and should not be a reward for good behavior. And the harm reduction component is that people do not need to meet requirements prior to moving in or to keep their housing, such as abstinence from substances, psychiatric stability, or even treatment attendance. And the residents of 1811 Eastlake are people with lived experience of chronic homelessness and alcohol use problems. And they were also individuals that were dubbed the highest utilizers of publicly funded services in King County. Things like emergency services, ER visits, jail, police services, etc. And I just wanted to note, because I think it's interesting to look at the narrative that was happening, and this took like literally 20 years ago when DESC proposed this type of housing. It did not come without controversy. Here are some of the newspaper ads that my colleague and I collated to document the discourse. There was great skepticism and doubt around the opening of these types of facilities. A lot of probably our own implicit biases and judgments. And interestingly, with the proliferation of homelessness in the past several years, we're actually almost seeing a repeat of this dialogue here, just more negative discourse akin to, I think, what we were seeing 20 years ago, but this time the solutions are not compassionate, pragmatic. Well, they might be pragmatic to the eyes of the policymakers, but they're not really. The solutions are things like, let's mandate people into treatment or force them into treatment. And they're more what I see as fear-driven solutions that I will put out there again have not been shown to be consistently effective. So I think that people want to make policies that are going to help people, but they're not necessarily always thinking about the implications and the human rights components of that. I'm happy to report that over a decade of research, or more than a decade of research, has taught us that programs like Housing First works. Here we see that Housing First resulted in over $4 million in taxpayer savings. It's associated with significant decreases in alcohol-related harm and also alcohol use, even though that people were told that they did not need to change their use in any way, associated with all sorts of significant decreases in jail days and jail bookings and emergency medical services, etc. And we know that housing is an effective solution to homelessness. And yet, as our city has continued to be one of the most rapidly growing cities in the US, we have not been able to keep pace and sustain affordable housing. We need to be thinking about wealth inequality, because we know that the gap between the rich and the poor is actually very predictive of many of the societal ills that we see. I also wanted to bust one more common misperception, is that people who are experiencing homelessness don't want housing, that they're making a lifestyle choice to live, on the streets. And that's simply not true. I think they just may not want high barrier housing that has been available to folks. They might not want conditions that they cannot abide by. And this is why Housing First has become such a successful model. We just need more of it. We need more affordable housing option, and we also need better mental health access for people to address the issues that we're seeing at play in our city. So I know I'm kind of going over, so maybe I'll hand it back to you, Caleb, and then we can go into a discussion. I haven't gone through all my slides, but I want to make sure we have time for discussion and questions as well.
Sounds good. And I'll just go over a few more things. You'll hear me coming back to that theme about forcing people into treatment is not only unnecessary, it's counterproductive. And so that's kind of where I'm going to go with the rest of my conversation here. And I'll just mention, similar to Seema, I mean, sort of my evolution through harm reduction started with HIV education and counseling in the early 90s. That's where a lot of our sort of harm reduction practices around bloodborne pathogens come from and continue, but also have not necessarily evolved that much in the 25 or 30 years since then. I've also worked in an opiate treatment program with people who use heroin who are taking methadone, certainly a form of harm reduction. I did medical social work at the VA, and I learned that most of primary care is in fact harm reduction. It's not about cessation of aversive health behavior immediately, or you get discontinued from care, which is often what we do in the context of substance use disorder. And so I think thinking more broadly about this is important. I will throw a few links in here. I'm going to not go back and forth on screen, but I am going to throw in the stopoverdose.org webpage, which we launched in 2010 when Washington became the second state in the country to have a naloxone and Good Samaritan law in place. I've learned a lot during that process. One of the things that we do in parallel with all this work is cooperate with our colleagues across the state, syringe services programs in a, thank you, Ron, in a syringe services program survey that we've done biannually since 2015. And I'm going to throw in a link to a paper that I think is really important. This is a former doctoral student, Vanessa McMahon, who got her doctorate here at the UW, and I got to work with. And I'll throw the link in here. And this is interest in reducing methamphetamine or opioid use. And what's important here, to Seema's point, is about 80% of people who are, say their primary drug is heroin, say they want to stop or reduce their use. We don't even bother asking them if they want treatment. We want to ask if they want to stop or reduce their use. And when we ask them what they want, 70% of people want methadone or buprenorphine, which are the most effective treatments. Many people are also interested in counseling, mental health care, and other things as well. So most people want to reduce their use. Most people are interested in a lot of things. Stimulants are a bit different. For methamphetamine, a little less than half of people want to stop or reduce their use. And that's really important. That's why the meaning and the actual value of substance use in people's lives is essential to take into context. There's a lot of functional things people get from a stimulant. It's why they're so widely prescribed. And for folks who are unhoused, who may need vigilance at night to not be victimized, who might need an appetite suppressant, who might need a mood enhancer, methamphetamine in that context is a pretty reasonable choice. And if you're going to do something to support people who use methamphetamine, telling them to stop using their methamphetamine is the first thing you do is just not going to work for at least half of the people, at least. And so thinking about a way to engage people, moving to an engagement first model, and harm reduction is really one of the best engagement tools that we have. It helps keep people alive in the short term, connects them to other human beings, and get perhaps a sense of self-worth and self-efficacy they may not have had, is really very, very valuable. We have adapted some of this work and built out a low barrier or low threshold approach to opioid use disorder, using the treatment medication buprenorphine at syringe exchanges, which is a major component of our work. I'm going to put a link in here from our webpage, learnabouttreatment.org, about that model of care. I won't go into a lot of detail now, but essentially it is our goals are to get people started on medications that day if they want to, regardless of whether they do or continue to use other substances. And we have good evidence from a pilot in Seattle that it reduces mortality and reduces illicit substance use. So we're very excited about that. I think what's really important, as I wrap this up, increasingly I'm really seeing and talking about the fact that harm reduction and treatment and recovery often do overlap. They are not mutually exclusive. And it's, I think one of the other ways I think about harm reduction is kind of embracing the gray in life. If you're thinking black and white or binary, this might be a hard thing for folks to get their head around. You either need to use or not use, be in treatment, not be in treatment, all of those things. This is really acknowledging the complexity of everybody's lives, and particularly folks who are dealing with, being unhoused, using substances, perhaps other issues as well. I would encourage you to be part of a conversation. Amy mentioned this Transforming Our Communities meeting. This is a meeting that we are really trying to bring people together around harm reduction innovations across the state. If you go on this webpage, you can see all of the proceedings of the last two meetings. These are the most energizing meetings that certainly I've put on and maybe that I've ever attended. So I would encourage you to take a look at that webpage. And also, I know Lisa's on this call and she's gonna be so excited that I put her email in there. So you can reach out to her if you want to be on the list or to be part of that meeting. But that is a really, really exciting group of folks from across the state, from policymakers to people with experience of substance use, to service providers coming together to talk about how we can do what we're doing now, educate people, engage with people to actually transform our communities to be, this the social worker in me, kinder, and a public health person in me, life-saving. We can do both of those things. And I think they're really important and valuable. It's very rewarding work. And I'm excited to have some more conversation and see what questions folks have.
Great. Seema, do you have a quick response or follow-up to Caleb before we open it up? Oh, you're muted.
Whoops, sorry about that. I would love to give our audience a chance to sort of ask questions. I did have a couple more points, and I'm worried that if I start talking, then I'll just take up all the time. So if we have time, I'll talk a little bit more about our treatment approaches.
All right. I don't see any hands in the air or things in the chat, so sneak in a comment.
If David has his hand up.
Oh, good. David? You have to unmute first.
I often do that. Sorry about the mute button. But Seema, I saw in one of your slides that you cited Alan Marlett, and in terms of his early work on harm reduction. And Caleb mentioned, how it takes 17, 20 years for these ideas to evolve. And I don't know if you wanted to, if either of you wanted to say anything about how the UW has sort of been at the forefront of many of these concepts and philosophies over the past 2 or 3 or 4 decades.
Yeah, that's a great, thank you for asking that, David. So yeah, Alan was my mentor. He was my introduction into harm reduction. I came to work at the university in 2003 as a postdoctoral fellow with Alan as my mentor. And I actually didn't really know very much about harm reduction. I really was through the involvement of the 1811 East Lake project that we were invited to evaluate that I actually formulated a lot of my opinions and, based on the evidence that we were seeing. And I think, harm reduction has been, and we have many, original harm reductionists on this call. I'm looking at Ron Jackson, who's also been one of my longtime mentors. So maybe Ron wants to actually comment on this piece too. But I will say, Alan used to talk about, not using the word harm reduction in our grants. He would often say, let's take this Trojan horse approach. And we will introduce these concepts that are showing to be effective, but we don't have to actually name it. And so I think there's Alan used to get death threats. He used to get notes on his car from the abstinence-based communities who felt very threatened by the idea that you don't have to quit using substances in order to get better. So I think there's been a real shift. And for me, the actual palpable shifting moment actually came through the LEAD project, what was originally the Law Enforcement Assisted Diversion, and then now it's called Let Everyone Advance with Dignity. There was a convening at the White House in 2016, Ron, 2015, 2016. And I remember my colleague, Dr. Susan Collins, and I standing in the West Wing and being in these meetings and just interspersing the word harm reduction as much as we could. And that being like a moment that I, was thinking Alan would be so proud, because we can name it. We can actually, people want to hear about these types of approaches that are effective. Not only effective, but also compassionate. And what better kind of combination? So, Ron, I would love to hear your response to that as someone who's kind of really seen it more than I have.
Thanks, Seema, and also Caleb. The two of you have done a wonderful job talking about harm reduction. And I think the takeaway message I would give everybody is that harm reduction is treatment. That there's not this great differentiation. You don't have to think of it as either or. So I'm going to set the Wayback Machine to the George W. Bush administration, where I was asked to be a contributor on the expert panel writing this treatment improvement protocol relating to the provision of opioid treatment program services. And we had this convening meeting outside of Washington, D.C., where one of the representatives from ONDCP, the drug czar's office, came and told us in no uncertain terms that there were 3 terms that we could not use in that document. We couldn't use condom, we couldn't say syringe exchange, and we couldn't say harm reduction. So the fact that now, there I was in the West Wing with you hearing all of this, it was a mind-altering situation. But now to see the current administration issuing grant monies that are basically harm reduction with the title harm reduction is a big sea change. It surprised me a lot, that thing that happened some years ago, because here we are in Seattle, and this is a relatively progressive city, and to see the level of resistance elsewhere in the country was astounding. And I'm going to shut up and say thanks. Thanks for all that you do, guys.
Thank you for being willing to pipe in there, Ron. I really appreciate it. Okay, Olga has a question.
Hi there. I was just wondering, in terms of harm reduction, when we're, I guess, trying to reduce harm of, let's say, methamphetamines or other stimulant drugs and whatnot, and you're moving somebody onto a different medication, is there a way that you would monitor their intake, because I'm assuming that there does come a point where if they take both, let's say, that the harm isn't reduced necessarily. So how do you even go about keeping track?
Caleb,
I
do
hope
you
that
want to
makes sense.
take that first, and then I can try and fill in as well?
Yeah, I want to make sure I understood the question, but I think it was generally around sort of if you're taking a harm reduction approach for folks who are using stimulants, and it's sort of a continuation of harm as they're continuing to use, how do you address that? Is that kind of the question?
No, it's more, you talked about alternative medications that they go on, but they don't necessarily stop the original drug. And how do you monitor if, I guess, what the toxicity of the two,
Yeah.
if there is like a limit?
Yeah, I think that, I did put in the chat Sams's definition of recovery, and I think that's really relevant. So a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So what that means in the context of both clinical care as well as research is that and in fact, FDA has actually changed their tune on this, in theory at least, is that the measure of effectiveness of a treatment or a medication doesn't have to be abstinence. It can really be about a return to functioning. And I hear what you're saying is that if people are continuing to use substances and they're continuing to have harm, I think that's an indication that we need to offer more, that we need to refine what we're doing and think about other things to do. I think the challenge has been historically is that when we are seeing this continual harm, I think providers and systems and others get fearful and often no longer want to work with that person, and often will discontinue their care with that person. And that disengagement, whether it's tapering people off of their opioid medications for pain too quickly, or whether it's refusing care for a person who continues to use stimulants, is pretty continually shown to exacerbate harm. So it really is trying to continue that engagement, even if the only thing you're doing in that meantime is continuing a relationship. That alone is your best chance. If you lose that relationship, if you lose that engagement, so many folks, they just continue to, they get more marginalized, more withdrawn, more isolated, and that pretty consistently leads to more harm. What would you say on that?
Oh yeah.
Yeah, I think, oh, sorry, go ahead, Olga.
So I was just going to say, I absolutely agree. I've had personal experiences when I have been cut off like panic disorder medications with no warning and not tapered off. And I had no idea that the pain that I was going to face. And my doctor was not very empathetic. He was more focused on the FDA regulations and the clinic getting docked, because apparently that's a thing.
Yeah, I'm sorry that you had those experiences, Olga. I was going to add to what Caleb said to say it's on us as harm reduction clinicians and providers to really work closely with the folks that we're working with to understand their personal constellation for us to use the resources that we have. I don't prescribe medication, for example, but I have contacts and I can find out, the onus can be on me to find out as much information as I can about, the interacting effects and all that, to share with, the person who's experiencing those things so that they have an understanding, then they can make a choice. So I think it's really on us to really understand and learn the specific constellations of the people that we're working with so that we can help tailor personalized plans for folks. But thank you for sharing that.
Yes,
know that-
thank you so much for speaking up. We do have one more question, or we have two questions in the chat, but let's get to the one that was up first from David Perlmutter. Could you talk about the ways in which you do engage community to develop your research priorities? And then how do people with lived experience, whoops, that went away, stay involved in conducting this research?
Yeah, I'm happy to start with that, Caleb. So, you know, there is a human rights lawyer, Brian Stevenson, who I greatly admire. And he often talks about proximity, being in proximity with a community and learning from one another. And I would say for me, and the way that we've engaged people in our work is by spending time in the community. Initially, that 1811 Eastlake evaluation was not a community-oriented study. It was looking at whether this type of housing was helpful to people on their particular journeys. It was what happened in between the assessments that we would do, the study assessments that we would do, the stories that people would share, where my colleague and I really learned like the real work was in those in-between stories. And so what we started doing was spending time in the community, you know, maybe putting together some focus groups where we would honor people's time to kind of share a little bit more about the things that they wanted to see happen. And it sort of evolved from there. We then started hosting a community advisory board. And so we really involved the community of people that we were, you know, trying to develop interventions or programs and services with. That community advisory board, until COVID, had been 7 years strong. And many members from our original community advisory board are still with us on different projects that we run out of the Heart Center. So we have weekly meetings where we're developing content or different ideas for people experiencing homelessness or with lived experience of homelessness. And we make sure to center those voices. So I would say spending time in the communities that you want to be working in, and then having kind of these formalized ways that you can work together with folks where you're able to also, we've been really lucky that our grants have allowed us to pay people. And I think that's absolutely necessary. I'm working on another project that it doesn't involve research in any way, but we're working to center the voices of youth and young adults in the University District to really try and address homelessness here in the U District. So it's about relationships. Maybe that would have been a much faster way, about building relationships and then having these formalized structures where people can really have their voices heard. So thank you for asking that question.
Caleb, any last words from you? We're nearly out of time.
I'll just say that it is a process that I'm always trying to get better at. And trying to be careful and mindful when we're doing work that we think is person-centered, but might really be pretty extractive. And that's something that as researchers is our default. I mean, it just is. And it takes a lot of time to put on the listening cap, take the listening time, sit down. And then really the hardest thing probably is to give up power. That is a big deal. And that is an ego issue, but it's also a time and money issue. I'll acknowledge those things as well, but it really is worth it and valuable. I mean, how many studies have we seen that we spent millions of dollars on that are so rarefied that when we go do them in a real world, they have no impact. And so I think let's make sure that we're doing work that is relevant and valid out of the gate. And so just from a research perspective, it's worth it, let alone as kind of, you know, the humane thing to do.
If you start with the community that you're working to serve, whatever you develop is going to be more acceptable and feasible off the bat because people have had a say in how it goes. So I think that's important to note. And I'll put our website in the chat because we do detail the projects that we're working on and have articles that you can read about community-based participatory research and engagement and all of those kind of things. So I'll try and.
Fantastic. Thank you so much to both of you. This was a great hour. It will be recorded and placed on our CHIPS website. And for the folks who are present, we'd love to have you join the third in our series, which will be April 20th, where Graham Pruss will come and talk with us about people living in vehicles. And he did his PhD here in anthropology on this topic and is now in California doing a postdoc and doing some important national work on living in vehicles. So thank you so much to everybody for coming, and we will see you in April.